Hello and welcome to Chapter 19, Diabetic Emergencies and Altered Mental Status. We're going to talk about pathophysiology, assessing the patient with altered mental status, diabetes, and other causes of altered mental status. So let's talk about a little bit about pathophysiology. So normal consciousness is regulated by a series of neurological circuits in the brain that comprise the reticular activating system, or the RAS. Okay, the RAS is responsible for functions of staying awake, paying attention, and sleeping. So exercise your RAS if you're having trouble. The RAS keeps a person alert and oriented. Requirements for the brain tissue of the RAS to function: your brain tissue has to have oxygen to perfuse, it has to have glucose to nourish the brain tissue, and it has to have water to keep the brain tissue hydrated. So causes of altered mental status include deficiencies in oxygen, glucose, water, trauma, infection, chemical toxins harming the brain tissue, primary brain problem, which would be a stroke, or a problem with another system because of hypoxia due to asthma. Okay. Assessing the patient with AMS. So the patient with altered mental status can be dangerous to responders. Always consider safety of yourself and your team before approaching a patient, and use law enforcement when necessary. Okay. Loss of consciousness with syncope is usually brief. The patient usually regains consciousness very soon after being allowed to lie flat. Hypoxia is one of the most common causes of altered mental status, and always consider the possibility of an airway and or breathing problem. So in our primary assessment, we're going to identify and treat any life-threatening problems, the ABCs, consider oxygen administration, be alert to the need for positioning and suctioning if the patient requires it or if their mental status worsens. These patients cannot maintain their own airway, so you have to be able to be alert to that. Okay, so then determine baseline mental status for a patient. What if the patient is normally not alert and oriented? What if they've had some type of brain trauma before and they're not able to speak, or they're not able to tell you what's going on, or anything like that? So you've got to determine what's baseline for the patient, and then what their baseline is now, and then we've got to determine if they're going to get worse or anything like that based on your findings. So in our secondary assessment, we're going to thoroughly examine our patient exhibiting new and unusual behavior. Even slightly altered mental status indicates a serious underlying issue. Okay, perform that primary assessment and determine if the patient's mental status is altered. Body systems exam and complete history may reveal information about the suspected cause of altered mental status, such as diabetes. Patients who are diabetic and their sugar gets too low, they can become altered, or their sugar gets too high, they can become altered. If they've had a previous stroke, it's something to take into consideration. Okay, or any type of breathing problem. So we're going to interview family members and bystanders to obtain the patient's baseline vitals or baseline mental status, and the family may provide information that the patient is unable to give. Patients' medicines may point to a relevant medical history. So patients who are on some type of insulin or other medication like that or even like a blood thinner for strokes can indicate what's going on. Look for medical alert bracelets. Again, those tattoos. The biggest ones that I've seen are the patients who have the tattoo on their wrist saying that they're a type 1 diabetic or type 2 diabetic. For pediatrics, the children may not be able to answer the questions in the same manner as adults, and therefore their mental status is often difficult to establish. With kids, it is hard to figure out what their baseline is. Typically, if you go back to like chapter 8, I believe, where we talked about development, and you kind of figure out what's going on there, they can tell you. I typically ask the kid, simple questions that they can answer, that they know. So like, if they're a little bit older, they know when their birthday is, or at least their birthday month, or something like that. I ask them to tell me their name. I ask them to identify their caregivers, parents. Who is this, and who is that to you? And that kind of gives me a good idea of where they're at. So what kind of information about a patient's altered mental status might you obtain from the scene? So we talked about it. So medications, family members, history. On the scene, you can look for medication bottles. You can look for alcohol bottles, even that. You can look for an oxygen concentrator. You can look for, they'll typically in their chair, because almost every single patient who has some type of issue will have a chair that they sit in, and all of their stuff is around their chair. So you'll see an albuterol, a home nebulizer treatment set up. You'll see an oxygen concentrator. You'll see all of their medications and various things. So look for those things. So what might bystanders help you identify the cause? How might bystanders help you identify the cause of altered mental status? They can help you by telling you the patient's history, their baseline mental status, and their medical history. Let's talk about diabetes. Glucose is a form of sugar. It's the body's basic source of energy, and the body's cells require glucose to remain alive and create energy. The glucose molecule is large. It will not pass into the cell without insulin. Glucose in the digestive system, so insulin and the blood sugar combine to enter the cell, and insulin is needed to help take the glucose into the cell. The pancreas produces that insulin. So insulin in the pancreas, it's produced by the pancreas. It binds to receptor sites on cells, and it allows larger glucose molecules to pass into the cells. Sugar intake and insulin production balance allows the body to use the glucose effectively as energy source. So here's the deal. So we've got these little insulin cells. So what they do is they go to the receptor site before the glucose gets there. And that receptor site accepts the insulin. And then that insulin says, hey, I need glucose. So then the glucose is able to pass into the cell to give the cell the glucose that it needs to remain alive and energetic. So diabetes mellitus, there are two types. Type 1 is that the pancreatic cells do not function and the insulin is not secreted normally. When not enough insulin is there to transfer into the circulating, into the cells, the glucose can't go in. Okay? Synthetic insulin is typically prescribed to supplement inadequate natural insulin. You may see an insulin pump on these patients as well, especially in pediatrics. They'll have an insulin pump. Type 2, the body's cells fail to utilize the insulin properly, and the pancreas is secreting enough insulin, but the body is now unable to use it to move glucose into the cells. This condition is often controlled through diet and or anti-diabetic medications. Okay, so hypoglycemia is low blood sugar, and the causes of this is that the patient takes too much insulin, they don't eat, they overexercise or overexert, they vomit, and they have an increased metabolic rate, which is like fever or shivering. So infections can cause the sugar to go low. Okay. Signs of hypoglycemia: has a very rapid onset, may present with abnormal behavior, mimicking a drunken stupor, pale, sweaty skin, tachycardia, rapid breathing, and seizures. So the results of hypoglycemia is that the brain cells are starved, there's altered mental status, unconsciousness, and maybe even permanent brain damage. Hyperglycemia is high blood sugar, and our causes of it are the decrease in insulin. It may be due to the body's inability to produce insulin, and it may exist because insulin injection is not given in sufficient quantity. Causes are stress, increasing dietary intake, so lots of sugars, carbs, things like that. The signs of hyperglycemia develop over days or weeks. There's a chronic thirst and hunger, increased urination, and nausea. With hyperglycemia, the results are profound dehydration, excessive waste products released into the system, and diabetic ketoacidosis. This diabetic ketoacidosis is pretty bad when you've got a patient who's profoundly altered. Shock can caused by dehydration. They've got rapid breathing, and they've got an acetone or fruity odor on the breath. So patient assessment: we want to ensure the scene is safe, perform our primary assessment, and identify the altered mental status. In our secondary assessment, we're going to do a history of the present episode, how the episode occurred, the time of the onset, duration, associated symptoms, and any mechanism of injury or other evidence of trauma, any interruptions to episode, seizures, or fever. Okay. We're going to perform our sample history, determine history of diabetes, question the patient or bystanders, look for medical identification bracelets, look in the refrigerator or elsewhere for medications such as insulin. Insulin has to be refrigerated, so it's probably in the refrigerator. And perform glucose monitoring if local protocols, which yours do. Okay. So blood glucose meters. They measure the amount of glucose in the bloodstream, often used by patients at home and sometimes used by EMTs. In Missouri, you guys are allowed to use a blood glucose meter to determine whether or not they have high blood sugar or low blood sugar or it's normal. Okay. All altered mental status patients get a blood sugar. I don't care what they are, you get a blood sugar because that's probably the easiest thing that we can fix out in the field. So they get a blood sugar. My opinion, as a paramedic, all patients should get a blood sugar, whether or not they have diabetes. Okay. So perform our secondary assessment. Take that blood sugar. So a blood glucose measurement less than 60 in a symptomatic diabetic is hypoglycemia. Less than 50, you've got significant alterations in mental status. This is not always the case. I've had a patient who had a blood sugar of 8 and they were still alert-ish and moaning and all that stuff. So typically if you get a patient who's less than 8, they're probably not going to be alert and oriented. They're probably going to be unconscious. So it was a big deal that this patient was actually moaning and alert. So Greater than 140 is hyperglycemia. Greater than 300 for a prolonged time includes dehydration and other more serious symptoms. When you have a diabetic, you want to ask them what their normal blood sugar is. Sometimes patients will run in the 300s on a normal basis. On a day-to-day basis, they will run at least 300 to anywhere in that range. So it's good to find out what their sugar is on a normal basis. So special glucometer readings, they may display a word instead of a number. High or high indicates extremely high level, usually greater than 500. And low usually indicates a low level, often less than 15. Like I said, I know that my patient had a level of 8 because that's what it came up on. So you've got to be able to know that too. So many diabetics use their at-home glucometer. This is basically every glucometer. Hospitals will have it a little bit bigger, but this is about the size that we carry on the trucks. So occasionally one can treat a person with mild hypoglycemia and minor altered mental status by simply giving something to eat. Okay, so something with sugar, followed up by something with a protein. Okay, you've got to administer that protein so that way that protein takes the sugar and breaks it down into a longer lasting sugar. All right, and never administer food or liquids to a patient at risk for aspiration. Okay, if they're too altered, they can't swallow, then obviously we don't want to give it to them because then they can aspirate. So oral glucose criteria for administration is history of diabetes, altered mental status, and that they're awake enough to swallow. The patient squeezes the glucose from the tube directly into the mouth. You can administer the glucose using a tongue depressor. We don't carry tongue depressors on the truck. If we're going to do that, we're just going to squeeze the glucose from the tube directly into the mouth for the patient, as long as they can swallow. So then we're going to reassess after administration. If the condition does not improve, consult medical direction about whether to administer more. So hypo and hyper compared. The onset, hyperglycemia has a slower onset, while hypoglycemia tends to come on suddenly. In the skin, hyperglycemic patients often have warm, red, dry skin, while hypoglycemic patients have cold and clammy skin. Their breath, the hyperglycemic patient typically has acetone breath, but not all patients will exhibit this sign, that fruity odor. Okay. So let's take a look at other causes of altered mental status. Sepsis is a collection of problems associated with a response to infection. It occurs when steps normally taken to fight infection move from the local site and become a systemic problem. If it's severe enough, the microbes of the offending infection can release toxins that harm cardiac output. So following findings indicate severe sepsis, altered mental status, increased heart rate, increased respiratory rate, low blood pressure, high blood glucose, and decreased cap refill time. Something else that can, when we talked about capno in a little bit, capnography can indicate sepsis as well. If your patient has a lower capnography reading, that means that they are retaining CO2, and when they're retaining CO2, they become acidotic, and when they become acidotic, then the body just retains all of that acid, and it can't push it out, and it can't get anywhere with it. So a low CO2 reading with other symptoms of sepsis, with any of these other symptoms, can typically mean that it's sepsis. So seizure disorders, if the normal brain function is upset by injury, infection, or disease, the brain's electrical activity can become irregular. Irregularity can bring about a seizure, sudden change in sensation, behavior, or movement. The seizure is a sign of an underlying defect, injury, or disease, and not a disease itself. There's two types of seizures. There's a partial and a generalized seizure. A partial affects only one part or one side of the brain, and the patient may not lose consciousness at all. Generalized seizure can affect the brain and affects the consciousness of the patient. Tonic-clonic seizures, typically the patient will be unconscious and have major motor activity. There's a tonic phase where the body goes rigid for about 30 seconds, and then the clonic phase where the body jerks violently for 1 to 2 minutes. This is the typical seizure that you see when you think of a seizure. Okay. It also has a postictal phase. So after the convulsions stop, there's often a slow period of regaining consciousness. The brain's trying to reset itself and say, hey, something major just happened, and I got to figure everything out. They may become altered during this phase. They can also become combative as well. So just be aware of that. Some seizures are preceded by an aura. It's a sensation that the patient has just before it's about to happen. The patients may note smell, sound, or just a general feeling right before the seizure. This is where seizure therapy dogs come in. That's what they smell. There's a distinct smell coming from the patient that dogs can smell very well, and that's where that comes in. So causes of seizures: hypoxia, stroke, traumatic brain injury, toxins, hypoglycemia, brain tumors, congenital brain defects, infections, metabolic problems, and idiopathic problems. Epilepsy, measles, mumps, and other childhood diseases. Eclampsia, which we'll get into when we talk about OB, and heat strokes, which we'll talk about when we get into environmental emergencies. So patient assessment. What was the patient doing before the seizure started? Exactly what did the person do during the seizure? How long did the seizure last? And what did the person do after the seizure? Sometimes we will get there while the patient is having a seizure. Sometimes we won't. Typically, we won't get there before the patient stops having the seizure. So we will get there in the postictal phase. So if you're present when a convulsion occurs, place the patient on the floor or ground and loosen any restrictive clothing. Remove objects that may harm the patient. Protect the patient from injury, but do not try to hold the patient still. So after they've ended, we want to protect the airway. If there's no possibility of spinal injury, position the patient on the side. If the patient is cyanotic, ensure that they have an open airway and provide artificial ventilations with supplemental oxygen. Patient breathing adequately may be given oxygen by mask or nasal cannula. Treat injuries the patient may have sustained during the convulsions and transport. Status epilepticus is when 2 or more convulsive seizures in a row without regaining full consciousness, or a single seizure lasting more than 10 minutes. So basically what happens is the patient has a seizure, they don't have a full, they have a postictal phase, but they don't regain full consciousness. They go right back into that seizure. That's what we call status epilepticus or status seizure. These are high priority emergencies requiring immediate transport to the hospital and possible ALS intercept, because we do have drugs that can stop that seizure. Okay. So not all seizures present as a generalized tonic-clonic. We've got partial seizures that are caused, that have uncontrolled muscle spasm or convulsion while the patient is fully alert, or a complex partial seizure, often preceded by an aura. And the uncontrolled muscle spasm is technically a seizure. What happens, I've had patients who have had like partial facial seizures where just like one side of their face was seizing, or one side of their body was seizing, or their arms were seizing, and not the rest of their body, and they were fully alert. So generalized seizures, we've got the tonic-clonic seizure, the absent seizure, or the petit-mal seizure, which is a brief without dramatic motor activity. They're basically, they have this blank stare, and they just aren't responsive to anything. Strokes. This is death or injury of the brain tissue from oxygen deprivation. It can be caused by blockages of arteries supplying blood to the brain, and or bleeding from a ruptured blood vessel in the brain. We'll get into it a little bit more when we talk about neurology, but signs are one-sided weakness, hemiparesis is very common, difficulty speaking or complete inability to speak, headache caused by bleeding from a ruptured vessel. This is less common but very important when a patient tells you that they have the worst headache they've ever had, or they feel like it was a loud thunderclap, or they feel like they've been hit in the head with a baseball bat. Those are very significant findings when the patient says those things. That could lead you to think stroke. Okay, so other signs and symptoms: confusion, dizziness, numbness, weakness, paralysis, usually on one side of the body. And it's the opposite side that the brain is affected on. So if it's the left side of the brain that's affected, then the right side will usually be the one that's the right side of the body will usually be the side that's affected. Loss of bowel or bladder control, impaired vision, high blood pressure, difficult respirations or snoring, nausea or vomiting, seizures, unequal pupils, headache, loss of vision in one eye. Unconsciousness is sometimes uncommon in a stroke. So communicating with a stroke patient can often be difficult to communicate with. Damage to the brain can cause partial or complete loss of the ability to use words. Aphasia is a general term meaning difficulty in communication. Dysphagia is that difficulty. Aphasia is the inability. So TIA, these are small clots that temporarily block circulation to part of the brain. It causes a stroke-like symptom. Symptoms usually resolve when the clot breaks up, and complete resolution of symptoms without treatment within 24 hours, but usually much sooner. I've seen a couple different TIAs, several, but ones that stick out are, we were at a football game for a standby, and we got there, and almost immediately we were called into the stands for a stroke, or a TIA, stroke-like symptoms. So we get there, the patient was definitely having a stroke. She had all of the classic signs. She had weakness, she had slurred speech, she was confused, she had dysphagia, all of that. By the time we got to the hospital, she was completely fine. Normal, with no problems. So, but you can't really tell if it's a stroke or TIA until the symptoms resolve. So how do we determine if a patient's having a stroke? Those signs and symptoms along with a stroke scale. The most commonly used is the Cincinnati Pre-Hospital Stroke Scale. We have actually switched to the RACE scale. And basically it kind of gives us a more pinpointed determination of whether or not it's a clot or a hemorrhagic stroke and what side of the brain it's on and various things. So with the Cincinnati Pre-Hospital Stroke Scale, the stroke patient is more likely to show an abnormal response. We're going to ask the patient to grimace or smile. I ask them to show me their teeth, stick out their tongue, because if they stick out their tongue and it goes to one side, that means that they've got some type of facial droop that you may not see readily on the face. Okay, so you can see their tongue is kind of off to one side where the facial drooping is. Ask the patient to close their eyes and extend their arms straight out in front of them for 10 seconds. What I do is, the way that I do this is I get them to grip my hands, and then what I'll do is I'll take a step back with their hands in my hands and hold them up, and I say, hey, I want you to keep your hands up for me and close your eyes. And I'm going to let go, but I want you to keep your hands up still. So I let go of their hands, and then if one side goes up or down, and they can't keep it up, then they've probably, that's, you know, it goes on that stroke scale as a point. Okay? So, ask the patient to say something like, you can't teach an old dog new tricks. I have them say, the sky is blue in Missouri, and repeat it back to me. And if they can do it without slurring their speech, then great. If they can't, then it's another point. So patient care. So for conscious patients who can maintain their airway, calm and reassure the patient. Monitor their airway, because these patients, because they all are altered, sometimes can't control their own airway. So we have to monitor that airway and reassess it often. Administer high concentration of oxygen for O2 sat that's below 94 if signs of hypoxia or respiratory distress are present, and transport. For an unconscious patient or patient who cannot maintain their airway, we want to maintain that open airway, provide high concentration oxygen, and transport. Transport suspected stroke patients to a hospital with capabilities for managing that stroke patient, and the capabilities must include a CT scanner at minimum. When you call in and you say that you have a stroke alert, you won't go to an ER room first. You'll go to the CT and get a scan done first, and then you'll go to a room. Or they may even, they'll take them to CT and then they'll take them up straight upstairs to have surgery, depending on what the problem is. So, yeah. Determine the exact time of onset of symptoms. There's a treatment that we can give, but it has to be given within a certain time frame. Okay, so we have to know what time the symptoms started. Document any contact information of the person who gives you that time of onset, or last saw the patient normal. All right, because the neurologist is going to want to know that. Dizziness and syncope. These can indicate serious or life-threatening problems, and they may be impossible to diagnose the true cause of syncope. Dizziness is a common term meaning different things to different people. Vertigo, which is a sensation of surroundings spinning around you, and lightheadedness, which is a sensation you are about to pass out. Okay. Syncope is a brief loss of consciousness with spontaneous recovery, typically very short, a few seconds to a few minutes. Patients often have some type of warning that a syncopal episode is about to occur. Causes of dizziness and syncope. They can have cardiovascular causes, such as bradycardia or tachycardia, which can decrease their cardiac output and cause syncope. A vasovagal syncope is thought to be the result of stimulation of the vagus nerve, which signals the heart to slow down and causes decreased cardiac output. This vasovagal syncope typically happens when people are on the toilet and they bear down very, very hard. Because what happens is that vagus nerve sits right there, and it causes, when you bear down, it shuts off that vagus nerve, and they vasovagal, and then they pass out on the toilet. You'll get lots of calls like that. Okay. Hypovolemic causes. There's low fluid or blood volume, which causes dizziness or syncope, especially when the patient attempts to sit up or stand. Remember, when you get up too fast, all that blood is now released, and or you don't have enough blood coming up to the brain, so when you get up too fast, you get dizzy. Okay, same process. We just may get dizzy and not have a syncopal episode. Metabolic or structural causes, so alterations in the brain chemistry with drugs or structure can lead to diminished level of consciousness. Inner and middle ear problems also cause dizziness or syncope. Kids with infections, ear infections, get dizziness. They can also have a syncopal episode. Environmental or toxicological causes, alcohol and drugs cause fluctuations in consciousness, and other causes. In half of the cases, no cause is found. Okay. So in our patient assessment, we want to rapidly identify and treat life threats, gather important information that will assist in overall treatment, ask the patient, have you had any similar episodes in the past, and what do you mean by dizziness? Did you have any warning? When did it start? How long did it last? What episode were you in when the episode occurred? Or what position were you in when the episode occurred? Are you on any medication for this problem? Any other signs and symptoms? Nausea. Did you witness any unpleasant sight or experience a strong emotion? Did you hurt yourself? Witness any involuntary movements of the extremities, like seizures? Okay. So in our patient care, we're going to administer oxygen based on their oxygen saturation levels and patient's level of distress. We're going to call for ALS, loosen any tight clothing around the neck, lay the patient flat, and treat associated injuries the patient may have had from a fall. So we've got to think about the fact that we've got to figure out if it's a seizure or syncope. Is the seizure or syncope a symptom of a larger problem? Remember when I told you that infections can cause a seizure? So infections can cause that seizure. So we want to know if they've had the flu, if they've had pneumonia, or if they've been sick recently, especially in patients who have epilepsy, have some type of seizure disorder normally, and they take medicine for it, because them being sick can cause that seizure to happen. All right, so chapter review. Diabetic emergencies are usually caused by poor management of the patient's diabetes. Diabetic emergencies are often brought on by hypoglycemia or low blood sugar. And the chief sign of this hypoglycemia is the altered mental status. So whenever a patient is in altered mental status, history of diabetes, and can swallow, administer oral glucose. Okay, remember to check that sugar first. Seizures may have a number of causes. Assess and treat for possible spinal injury. Protect the patient's airway and provide oxygen as needed. Gather information about the seizure to give to the hospital personnel. A stroke is caused when an artery in the brain is blocked or ruptures. Signs and symptoms of a stroke include altered mental status, numbness or paralysis on one side, and difficulty with speech. For stroke patients, we're going to ensure that open airway, provide supplemental oxygen as needed, determine the exact time of onset of symptoms, and transport promptly. Dizziness and syncope may have a variety of causes. In the case of syncope, we're going to administer oxygen, loosen any clothing around the neck, place the patient flat with raised legs if there's no reason not to, and treat any injuries and transport. So critical thinking. You have a 62-year-old male is witnessed to have a tonic-clonic seizure. You find him actively seizing. His skin is pale and moist and slightly cyanotic. Discuss the treatment, the immediate treatment necessary. So if he's still seizing, we can't really do anything until he stops seizing. So after he stops seizing, then we're going to apply oxygen, maybe BVM if we need to, do anything like that. And then we're going to rule out any kind of signs and symptoms of hypoglycemia, hypoxia, or stroke. All right? All right, so if you have any questions, let me know. You can call me, email me, text me, anything, okay? And I will answer those questions. I will see you in the next lecture.